Good morning, everybody. This is Mark Erkin, and welcome to our Friday morning's virtual session here. It's really my pleasure to introduce Dr. Maria Brito, who is a valued colleague and friend at Mount Sinai. She is a board-certified endocrinologist and director of the Mount Sinai Thyroid Center that's located at Union Square campus. Prior to her joining Mount Sinai, Maria created and she directed the thyroid unit at Northwell Health, where she developed a multidisciplinary program for thyroid care, and she also ran the endocrine fellowship program. In addition to being a board-certified endocrinologist, she is also certified in ultrasound by ECNU, and she's also accredited by the American Institute of Ultrasound Medicine. Since this morning's talk is dedicated to the development of a thyroid center, I will also allow her to describe in detail the Union Square Thyroid Center which she directs. It happens to be quite fortuitous that I've had just in the past 2 weeks here 3 separate phone calls from individuals whose medical centers are looking to create a multidisciplinary center, and I have advised that they tune in this morning to get the nuts and bolts of how to do that successfully. So with that, I'm going to turn over the program to Dr. Brito and encourage, as we do every week, you to send in your questions, which we will do our best to get to before the end of the hour. So with that, Dr. Brito, thank you in advance for agreeing to present this morning.
Thank you. Thanks so much, Mark. So I was asked to just speak to our experience here, basically just a rundown of what we did, why we did it, and how it's working. And hopefully you can gather from this talk, if that is an interest of yours, some elements that I think are useful to develop a thyroid center. We have some unique advantages to our campus. That is not necessarily a system-wide advantage of Mount Sinai, but specifically to Union Square. So even though you may not necessarily in your location have those specific elements, there are components that I feel are most essential and are replicable for a thyroid center. Frequently, the expertise is there, the interest is there, and it's really just a matter of alignment and coordination for an endeavor like this to happen. So the aims of my talk are to present what the objectives are behind creating a multidisciplinary thyroid center, to describe our thyroid center here at Union Square, and hopefully provide some recommendations into creating a thyroid center of your own. There are several objectives in trying to create the center. When we were approached, Dr. Erkin, myself, and in that time, Dr. Inabnet, and also Dr. Terry Davies, about launching a thyroid center, we had to make sure we were very clear on what we wanted to accomplish and why we were doing this. So the first thing is to provide a seamless patient experience, to provide expedited and quality care. So we wanted to make sure that the patients were not only seen quickly, that we minimized the kind of back and forth that can happen in patients who are seeking thyroid care, and that they were seen by the best experts that the health system had to offer in all of the specialties that are in charge of taking care of thyroid patients. We also wanted to make sure that we enhanced communication and coordination among all members of the care team. We also personally wanted to establish a setting for discussion of complex cases and develop personalized treatment plans for those patients so that their care doesn't get lost and that we're all in agreement. And we also wanted to provide a setting that was cohesive for clinical research and innovation. So this is what we most frequently see in practice, and I'll show you kind of a diagram of how that is translated in our thyroid care patients. Fragmented care. Fragmented care basically means patients are seeing different doctors, different locations. Doctors and results are not always expedited and communicated between each other. There's usually a lag between the time the patient gets a diagnosis and the time the treatment is accomplished. And, you know, fragmented care, we know, is associated to poor outcomes and decreased patient satisfaction. So that's something that we definitely wanted to resolve. And one of the ways to help that is to reduce friction. Friction is just an overall concept of kind of challenges, difficulties, hurdles that make things, you know, more difficult, longer than we would want them to be. So in reducing friction for the launch of the Thyroid Center, we wanted to maximize the visits, studies, and procedures that a patient can have done on the same day. So we wanted to be able to provide the endocrinology consultation, the neck ultrasound, the fine needle aspiration, labs if needed, are needed, and also, you know, the surgical consultation, if possible, on the same day. And if we can get those same day results of those ultrasound reports, rapid on-site adequacy by cytology, and cytopathology results of Bethesda categories, we were on the right track to be able to accomplish that. In addition to reducing the friction, another way to combat fragmented care is to have seamless coordination. So the kind of main departments, these are not all of the departments that are sometimes seen in thyroid patients, but these are the most frequent departments, particularly in thyroid nodules and thyroid cancer, are endocrinology, radiology, pathology, surgery, and nuclear medicine. And the way we came up to solve any issues in coordination is to have a unified and cohesive thyroid center coordinator or coordinators, which we've had 2 in the past, in order to streamline and keep communication amongst all these departments and make sure that scheduling and patient advocacy is present with this kind of core individual that makes sure to walk the patient through and navigate the patient through their disease care process. Another goal is to have personalized treatment plans. Yes, certainly we want strong adherence to evidence-based medicine, and the use and adherence to guidelines is quite mainstay. But there are some patients that, I'm sorry for the typo there, that do fall into the gray zone for radioactive iodine treatment, whether, you know, either it is the size or the aggressiveness or lack of aggressiveness of a tumor, in which there are some features that would maybe prompt us to consider radioactive iodine and others not. And so we want to have a discussion as to, you know, does this patient really benefit from radioactive iodine in some cases? There are also some uniquely challenging cases, either due to the patient's specific personal goals, their age, their comorbidities, or the nature of their pathology that would warrant a multidisciplinary discussion. And lastly, we wanted to provide a setting that was fertile for research and innovation. And the goal of research and innovation is ultimately to improve medical care. And we can achieve this with, you know, new information, looking at new approaches to traditional management or new treatment modalities. Having that in place and possible for the faculty and all of the departments can also enhance the patient experience, either because patients like the idea of being specifically in an academic medical center that can provide that experience, or just the knowledge that they're being cared with the utmost quality. And also having this can increase the stature of the center in the community. Our thyroid center here at Union Square is is an endeavor that has multiple stakeholders. This is the outside of our building. It is very strategically located. For those of you who are familiar with New York City, we have, I think, more than 8 subway lines that navigate right under our building. So patients from all parts of the boroughs and even Long Island through the Long Island Railroad are very easily able to commute to our location. So that is very unique to this specific geographic area, which is one of the reasons why the Thyroid Center was launched here at Union Square first, rather than in the other sites in which thyroid care actually does happen. But there are these advantages to this location in addition to providing patients easy access via commuting, but also because of the amount of departments that are in this single building. Here in New York City, most healthcare systems have multiple building sites where care is provided. And so you may have an office building in which you have a couple of subspecialties. You may have radiology in the inpatient hospital building, and nuclear medicine may be there. You may have different subspecialties like hem-onc and surgery and endocrinology in different buildings. So it can, even in places where you have multiple departments, it is not as a comfortable patient experience and is easily sometimes coordinated as it can be in a building such as our own. So if you look at this building, and just confirming that everyone can see my mouse, you have here, for example, where my mouse is now, the suite where our head and neck colleagues are, led by Dr. Erkin here. We have endocrinology that is down here in the second floor. You have general endocrine surgery here also on the second floor across from endocrinology. You have radiology here in the third floor. The lab is here next to that suite. And kind of opposite on the other end, we can't really visualize in this picture, we have our pathology, hem-onc, and radiation oncology colleagues, as well as our newcomer, which is ophthalmology. So this is a diagram of a traditional patient journey who may have ultimately been diagnosed and treated for thyroid cancer. So you see a patient who comes in for their annual checkup with their PCP. Perhaps her PCP notes a palpable nodule on physical exam. Due to that, the physician orders a TSH and an ultrasound. The patient goes ahead and has that done in a laboratory, and also a radiology visit is made. The radiologist performs the ultrasound and notes in the report that the patient may have a 3-centimeter suspicious nodule and is recommending a biopsy. Once that result is sent to the PCP then reviews that and orders a biopsy for the patient. The patient then goes on to make a visit either with a radiology department that does interventional procedures like biopsies, or in pathology departments to have a biopsy done. The pathology department then finds that, reports ultimately that the biopsy is Bethesda 6 and confirms thyroid cancer, for example, and then send those results to the PCP. After the PCP, gets those results faxed in or streamed into their electronic health record, decides to refer to endocrinology. At that point, an endocrinology visit is established, and once the endocrinologist sees the patients, if this workup has been done, sometimes the endocrinologist sees the patient in the front end just with the knowledge of the nodule, and then goes through that process. And then decides, okay, this patient has a Bethesda 6 nodule, needs to be referred to surgery. Once the patient then leaves our endocrinologist, sets up an appointment to see a surgeon within a week or two, and hopefully then leaves that visit with a date to go to the OR. After surgery, then the patient is seen for their post-op visit, then seen by an endocrinologist. Depending on when they're seen, they may need, if they're seen very soon after surgery and the endocrinologist needs more information, they may need to have 2 visits with the endocrinologist, then ultimately possibly referred for radioactive iodine treatment. And then they receive the radioactive iodine treatment with nuclear medicine. That can entail up to 4 visits depending on whether or not thyrogen is used. There could be 5 days of in-person visit evaluations leading up to surgery, with a total end-to-end accumulation of visits of 7 visits if the patient doesn't have radioactive iodine treatment, or up to 11 visits if the patient does have RAI treatment. And this is all obviously making sure that the patient has awareness. We all have information gathering, making the diagnosis and treatment plan, and then the follow-ups and the relationship building that occurs after that. So in our model, we wanted to streamline this significantly. So, after the patient is seen by their PCP and they find that nodule, perhaps sends, labs for their thyroid, they can immediately refer to the endocrinologist. And in our suite, the endocrinologist would then perform the ultrasound, decide on the biopsy, perform the biopsy, have those slides read immediately by pathology that's in the 4th floor, replicating the previous case. If the biopsy is read as Bethesda 6, we get that information in real time. We then send the patient either upstairs to the 5th floor or across the hall, depending on which surgeons are there that day. And then that patient is seen by the surgical team and leaves the same day with the OR date. After that, a thyroidectomy is performed. They have their 2-week, usually it's around 2 weeks that they do the post-op follow-ups for surgery. I'm sorry, that's a typo from a previous slide. I really apologize. 6 weeks after that, which is something that we incorporated, we started realizing that patients were being seen soon after surgery, and due to both recommendations from what we've seen evidenced in the literature and our own clinical experience, we realized that having that 4 to 6 week post-op thyroglobulin was very key in our decision making as to sometimes whether or not the patient was going to receive radioactive iodine. If the pathology report, the histology was inconclusive of our decision to do that. And we can also then at the same time decide how much radioactive iodine we would want to give as a result of that as well. That can also play into our decision making. We also, at that point, the patient has been on treatment since their surgery with levothyroxine. Because we can risk stratify at that time, decide on making the adjustment of their thyroid dosing medication as well. And most recently, not just doing the 6-week follow-up with the endocrinologist to get those labs, we're actually doing it prior to that 6-week follow-up. So now the endocrinologist, when they see the patient, already has the information to go ahead and make that decision without having to wait for those results to let the patient know what the next step is. And then the patient can have radioactive iodine treatment, which can be up to 4 visits if thyrogen is used, which is what we most commonly do. In this model, the patient at the thyroid center has just 1 day of evaluation to proceed to surgery. And the visits end to end in total are either 3 visits without radioactive iodine or up to 7 visits if they get radioactive iodine. So this entire progression is significantly reduced, condensed, and made more expeditiously for the patient. You can imagine that in addition to just reducing the patient's time to not have them take so many days to see different doctors at different locations, it also gives the patient the feeling that things are moving quickly and that their disease process is addressed expeditiously. So our thyroid center has multiple departments and specialties. So in this Suite 2F, we have our endocrinology team. In Suite 2L, we have the general surgery endocrine surgery team. In Suite 5B, we have our head and neck team. Our medical oncology colleagues are in the 4th floor, Suite 4C and D. Radiation oncology in 4F, pathology in 4J, general radiology in 3P, ophthalmology, which we now have in Suite 3J. It is general ophthalmology. Oculoplastics is still 2 blocks away at the New York Eye and Ear. And our nuclear medicine team is on 34th Street, very nearby. So how did we accomplish this thyroid center integration? The first thing is to have all departments invested. The fortunate part of this endeavor is that all of these different departments are not just co-located, but they are also very interested in this model working and having the patient satisfaction that goes along with it. We also are very interested in collaborating together, both for management of challenging cases and in research as well. We accomplished this also with a central thyroid center coordinator. So that coordinator has streamlined the contact with all of the administrative assistants from the different departments, schedulers or secretaries that are involved with nuclear medicine, surgery, radonc if necessary, and our general radiology departments. The patients identify this coordinator as their personal advocate and navigator, and they are held accountable for making sure that all steps in the patient's care are appropriately given. All faculty members can contact each other directly about cases, either via our cell phones or emails. So we all know each other and we contact each other very readily to inform each other of what's going on. So much as to myself, giving a call to Mark Erkin the morning of surgery of a parathyroid case, for example, that there might have been a discrepancy, just things to look out for because of what I saw, or giving us vice versa a heads up about a case where they saw some findings macroscopically in the OR that may or may not necessarily be reflected in a pathology report, so that we understand what we're dealing with on the other end. The unified electronic health record has been instrumental. So when we actually started our thyroid center, we were in different EHRs. So that was a little bit of a hurdle that we still overcame very well with the thyroid center coordinator. But then this has also reduced that layer of friction that can happen when there are different doctors, different locations, different health systems. So that is very, very helpful as well. As I mentioned, the glue for all of this to happen is the thyroid center coordinator. There is a 1-800 line or a 212 line as well for the thyroid center that is manned by this thyroid center coordinator. I'll give a caveat. We had 2 thyroid center coordinators prior to the pandemic, and we lost our thyroid center coordinators and had a hiring freeze for over a year. So you can imagine everything that we've dealt with. But we had now, thankfully, have another thyroid center coordinator who has been fantastic. And so she shares this thyroid center line with the call center, but within our departments, they contact her directly. So the surgery department or the nuclear medicine department does not, contact our coordinator through the call center. They contact her directly to have her direct line. The thyroid center, I must say, is not just a thyroid cancer center. Obviously, that's one of the most important components of our care and one of the most elaborate components of our care. But patients with clinical non-surgical thyroid disease are also seen. So when they call the thyroid center, quickly we need to assess what was the reason for the consult. If it is one of the reasons for clinical thyroid disease like Hashimoto's, Graves' disease, and hypothyroidism, whether or not the patient has pregnancy with an abnormal thyroid test, they are to determine, okay, are you calling the center because you want to establish care with a new endocrinologist, or do you have an existing endocrinologist and you're seeking a second opinion? And then the thyroid center coordinator would know whether or not to seek records of previous care. The same, and then obviously set up the appointment. The same with thyroid nodules and the history of a cyst or a goiter, has not necessarily had a thyroid cancer diagnosis yet. You know, does the patient have an endocrinologist or not? And if they do, if they've been seen before, then we would get those previous records ready for the appointment. And if that endocrinologist, because there's sometimes we have actually had some endocrinologists refer to us just to streamline their care with biopsies and surgery, and then they go back to their endocrinologist. If there's a thyroid nodule that, based on those results, will require a biopsy, whether or not they need a biopsy or an ultrasound, if they have an endocrinologist, sometimes they would bypass our endocrinology division and be seen by radiology and pathology, get those results, and proceed with the surgeon. And obviously, if they don't have an endocrinologist, then they'll have everything done with the endocrinology team in the second floor. This is key because our surgeons are not just fed by the endocrinologist in this building. They have to, in order to have high volume, have a wide referral base. And having our surgeons be high volume is very important to us. And we never want the endocrinologists in our community to feel like as soon as they're seen at any point in the thyroid center, that's a patient that they're not going to get back, because then that would steer them away from referring to our surgeons, which is very, very important to us. And obviously, if there's a diagnosis of thyroid cancer, depending on whether or not this is just a biopsy that then would need the evaluation of an endocrinologist and a surgeon, or if this is a patient who has had a history of thyroid cancer and has had recurrences, or is seeking a second surgical opinion, or is maybe looking at another intervention, we would want to get all of those reports from where they are. So the thyroid center coordinator has a lot of heavy lifting to do to make sure that everything is in place for these visits. So in addition to that coordination and that navigation through all of our departments, we also have a multidisciplinary thyroid tumor board that occurs on a monthly basis. During these tumor boards, we review surgical findings, intraoperatively pathology findings, biomarkers, and imaging to make decisions on our challenging cases. Some of our bread and butter cases can have some challenges. We have had patients who are either planning fertility soon after a diagnosis of thyroid cancer, and we need to decide on whether or not it's reasonable to delay radioactive iodine treatment, or who are breastfeeding, and what do we do? Is it aggressive enough for us to say that they need to stop breastfeeding and we need to treat? There could be some decision making about age and functional status if we have a diagnosis of thyroid cancer, about how aggressive to go, either with whether or not to do surgery, and if we're doing surgery, how aggressive to be, whether it's going to be palliative or not, and if there are other comorbidities that are complicating this other kind of standard thyroid cancer case. Then we have our actual aggressive cases. We can have anaplastic, aggressive histology like insular, or multiple recurrences, a severe amount of lymph node involvement, metastases, or significant invasion to vital structures, in which we need to kind of discuss how we're going to manage that, either with different surgical techniques or advanced like TKIs, whether or not they may even need ethanol or radiofrequency ablation for recurrences, what dose of RAI to decide on, do we need dosimetry, and sometimes we also get pre-treatment scans, because there are some cases that we see them 6 weeks post-op, their thyroglobulin is higher than we'd like them to be, or their histology is just aggressive enough for us to suspect that there may be metastases, and we want to get dosimetry and pretreatment scans to determine if there is metastases, or whether or not they need other advanced imaging like, PET scan and so forth. This on the left is what our tumor boards more or less used to look like. We used to be in this large conference room. We used to have all of those departments kind of there physically interacting with each other. And on the right is what things look like now post-pandemic. We're reviewing all of our radiology and histology and biomarkers and discussion. Everything happens now through Zoom. Which has been helpful for some who have had some challenges coming physically to our location. We have one of our head and neck surgeons, for example, was based out of our West campus actually, and had to commute to be on site, and that really facilitated things for her to be in person. That was Dr. Catherine Sinclair, who now has moved back to Australia, but it has been helpful for a lot of us who are in different locations. Research, so we have different avenues in which research happens. So we have the Davies Laboratory. That is a basic science research lab. It has multiple protocols, primarily studying pathways of thyroid autoimmunity. And on the left there, you see a picture of Dr. Davies with the main personnel in his research team. Through the THANC Foundation, as many of you know, there is a lot of thyroid cancer clinical research that happens through what previously was the database, but there's a lot of collaboration, both in surveillance of thyroid cancer and management of thyroid cancer, characterization of different clinical stages. And there are some individual research projects also that occur in nuclear medicine and oncology. Years back, they had redifferentiation protocols with medications like selumetinib for that. And our endocrinology faculty, such as myself, and our surgical faculty also sometimes have individual protocols. I have a specific interest in thyroid microcarcinoma that have 2 IRB protocols underway, and our surgical faculty have also looked at in the past molecular markers and prediction of thyroid cancer. We also offer some new approaches, or relatively new approaches. A lot of us are familiar with these now: ethanol ablation and radiofrequency ablation. Our head and neck team also does a lot of fancy work surgically with advanced reconstructions in patients who have had significant invasions to vital structures, and our general surgery team also offers remote access thyroid surgery to some few selected patients. What are our current challenges and ambitions? We have a huge access issue. So a thyroid center in a large health system like ourselves that underwent a lot of heavy marketing. So my apologies for not including that. Was one of the things that also occurred as part of our launching process. We had a marketing program that occurred through social media that was picking up leads for a total of 6 months that accrued a lot of patients to our center. But the access issue has become really impactful for 2 reasons that I'll mention now. But I want you guys to know that one of our goals at the outset, and it's still one of our goals that has been a big challenge to meet, is a 72-hour window for an appointment, a new patient appointment. There's multiple reasons for that. Endocrinology as a specialty is underserved. So the amount of endocrinologists that graduate every year versus the need in the community is quite disproportionate. In addition to that, aside from myself, there is no other endocrinologist that is a solely thyroid-focused practice, that has a solely thyroid-focused practice. Dr. Davies, who now has moved his practice entirely to the Uptown campus, was also there with me seeing thyroid-only patients. Due to his basic science research, was here limited at like 1 or 2 sessions a week. but I'm the only one that's seeing thyroid patients exclusively, and then the rest of my faculty colleagues are also seeing patients in the weight management program, general endocrinology, and diabetes program. So that's one of the reasons. The second reason is that we have now that we're in the second floor, we used to be in the fourth floor. We had our own kind of isolated location there. We're co-located with the rest of the endocrinology team and nephrology and allergy. So our actual physical space is limited. And although we were forced to do basically virtual visits close to anywhere from 30 to 60% of the time, we have now realized that it is a necessity due to the actual footprint that we have in the building. So I myself am only seeing live patients twice a week, for example, and I'm doing exclusively thyroid patients. So you can imagine how that has also impacted the rest of the thyroid center for the endocrinology colleagues themselves. How are we combating that? So we just recently launched something that I believe will enter into effect in January, which is a template change that is basically favoring new patient appointments. So so we're not clogging up our schedules with follow-up appointments, and the new patient appointments are protected. And we have now given our thyroid center coordinator specific access to appointments that are favoring our surgical colleagues. Due to how booked we are, that doesn't really enter into effect until January, but it's something that we have to continue to raise with our administration because we need to make sure that patients have adequate access. It's one of the main goals of our center. We obviously need to grow. We don't have enough endocrinologists. The ratio of endocrinologist to surgeons needs to be higher. We have a new general endocrine surgeon that's going to be entering to our building in December. That's going to make a total of 6 high volume thyroid surgeons that we're expected to serve our community within the same building in Union Square. So we need a higher ratio of endocrinologists to serve those surgeons, and we don't have currently, unfortunately, the space to be able to bring more endocrinology colleagues. And if it were up to me, thyroid-focused endocrinology colleagues to better serve them. And an ambition of mine is, to replicate a thyroid center like ours system-wide, and to create something that kind of looks like this. I'm currently the director of the Union Square location, and we have our surgical leads, Dr. Erkin and currently Dr. Owen. We have administrative support staff, clinical support staff, and research support staff. But it would be nice to have a system-wide endeavor and someone that can oversee a location at the Morningside West campus and also at the Uptown campus. There are also both endocrinologists and surgeons that are thyroid focused in those locations. They do not have the specific building structure and co-location the way we have it, but they can have a different model that can tailor their needs. In terms of starting a thyroid center, my recommendation is to look at the patient journey and to focus on the main component, the essential departments that can streamline the care. And that is endocrinology, surgery, and pathology. If you noticed how we condensed that visit for the endocrinologist to do the ultrasound, do the biopsy, send the patient that same day upstairs or across the hall to surgery, and the patient leaves the same day with an OR date. I think that would be what I would start with and focus on when you look at about a thyroid center. Yes, nuclear medicine, oncology, radiation oncology, the general radiology department, those are all, and an ophthalmologist that could look at your Graves' eye disease patients, those are all great. But for a thyroid cancer and just a general nodular thyroid disease or thyroid goiters and clinical care, you can really accomplish a lot if you can just consolidate those 3 departments. And if you can't have all 3 departments there all 5 days a week, maybe just deciding on, when can we all get together in a physical location that is proximal and um, uh, comfortable enough for the patients to be seen in this expedited way. At the very least, I would say, if you can't co-locate, have a thyroid center coordinator that is cohesive to all of your departments, that can make the patient have that feel of kind of a concierge, streamlined, expedited process. A key component is to obviously have endocrinologists that have an interest and experience in neck ultrasound and biopsies. We know that we want to have high volume thyroid surgeons. So we do have, thankfully, a good amount of highly skilled thyroid surgeons that we can refer to. The thyroid center coordinator, I feel, is essential. Alignment amongst all teams is also important, and a reliable radiology and nuclear medicine department that, even though they're not necessarily co-located, these are people who have provided you with quality ultrasound reports, quality CAT scans, and radioactive iodine studies. The steps to take are to sit down and have a strategic planning session because we are a large healthcare system and there's a lot of administrative bureaucracy. These were multiple meetings. I mean, we met, I think, if it wasn't weekly, up to monthly at a 7 a.m. on a Friday, because as we know, surgery, different surgeons and endocrinologists and pathology and nuclear medicine doctors aligning with their schedules is very hard. But we all, woke up early in the morning and made those 7 a.m. conference calls and made this happen. Like I said, making sure that you just have a location, days, times, something that a thyroid coordinator can work with, establish those patient workflows. Dr. Erkin and Dr. Inabnet were very, very key in supplementing our endocrinology workflows with what their surgical workflows are for that patient navigation, establishing some intake questions for these coordinators, and then optimize along the way. Figure out, what's working, what's not, and what we can do better, and go ahead and start. I want to give a very special thank you to Dr. Mark Erkin, our lead surgery from our head and neck team, our former division chief and highest thyroid expert within the health system, Dr. Terry Davies, who is also my mentor, and Dr. Inabnet, who is no longer with us, who was the lead surgeon for the general endocrine surgery team. Thank you.
Thank you, Maria. That was great, and I think very comprehensive here. We've got a number of questions that have come in, and I would like to give you sort of shoot them at you here and see how many we can cover before the end of the hour.
Okay.
What is the one, if you could choose one thing that patients want most, just to fine tune that, I think coming back to the thing that drives the patient experience, what would you say is the most important thing that that you need to concentrate on?
I think that patients like speed. So I would focus on what we can do, as I've outlined, to reduce steps in the patient care process. So I think that the patients really like being seen and having their diagnosis made expeditiously, their care plan done expeditiously. And so I have to say, being seen, patients that leave my practice and are told, all right, you need surgery, go upstairs and see the surgeon, their eyes light up, like, I can do that today. Yes, and we've seen patients who've had like refractory Graves' disease for example, for years, and it just takes one endocrinologist to tell them you need surgery, and the surgeon is here to see you today and leave that same day with a surgical plan. It is a huge relief for them, because particularly in our location in New York City, and I'm sure this is in a lot of places, patients really feel like their time is valuable. So having to do a lot of steps to see different doctors is very cumbersome, and they can get lost to follow up. I mean, I've seen patients who have been recommended to have surgery for very large goiters that are causing compressive symptoms for years, but they've kind of, they always tell me to see a surgeon. I get a phone number and a name, and I never really schedule that appointment, or I never make it to that appointment. So I think the speed is what I would focus on, and reducing patient visits.
Great. Thank you. And another Dr. Brito from Rochester, Minnesota. I assume no relation here. Would like to ask, how much time do you allocate for new versus return visits?
So our surgical colleagues have a different model, and I am actually not entirely attuned to how long they do their visits. They have a larger team of mid-level providers, and also we do have trainees in our division. They are not always present in the thyroid sessions necessarily. Some of them are manned with residents, and some are not. But they have, I think, regular presence of mid-level providers and residents, and I think a fellow for head and neck surgery as well, that would, and endocrine surgery also has a fellowship that help increase the amount of patients that they can see in a day. So we have 40 minutes for new patients and 20 minutes for follow-ups.
Great.
In endocrinology.
Okay, terrific. Can you speak a little bit? You mentioned this more from a space constraint, but with the emergence of telemedicine during the pandemic, in terms of what patients want, how are you personally integrating which visits are done virtually and which ones do you insist on being live? Can you sort of give us some guidelines for that?
Yeah, so from the endocrinologist perspective, I'm looking at the thyroid cancer patients specifically. The 6-week post-op appointment, a lot of my patients have enjoyed virtual because they don't have to, I mean, at that point, they've had the endocrinology visit, the surgery visit, they've been in the hospital, and that's fatiguing in itself, or in the OR. And they're kind of, they've been recovering. Some of them would have to go back to work at that point, and they've already had multiple visits. So having them be able to, either from their place of work or home, be able to virtually discuss their pathology, their histology, their biomarkers, their thyroglobulin level, where it's at, and the consensus that we've come to in regards to whether or not they're going to need radioactive iodine, if what dosing they would need, and if or not that dosing is still not ready to be made, because based on the results that we have so far, they will need a pre-treatment scan. That is hugely helpful. So the immediate kind of window to decide after surgery for radioactive iodine, that can be a virtual appointment, and patients appreciate it. Within the first 6 months, the patient does need to be seen in person, and Dr. Via, myself, Dr. Kim, we would like to do like a follow-up ultrasound at that time, so that is an in-person appointment.
Great, terrific, thank you. Dr. Gonzalez Velasquez from Mexico would like to ask if you could elaborate a little bit on the patient journey for those patients who are undergoing active surveillance for early stage thyroid cancer.
Yeah, so patients who are undergoing active surveillance have an ultrasound frequency every 6 months, and we would do that at least for the first 5 years. That's just how we mostly feel comfortable with these patients. So active surveillance frequency is within, every 6 months. if they were to already have a benign biopsy. We have varying styles within our division in terms of the endocrinologists with following up ultrasounds of benign thyroid nodules. But I can tell you from my own practice, if a nodule is benign, I follow that ultrasound up in a year. And if it's stable, I start spreading out the intervals every 2 years, 3 years, and so forth until I get to 5-year intervals.
Great. Could you, one of our questions that's come in really relates to how you integrate with community care team. So these patients come in, they sort of get locked into the care center team, but what's done to make sure that the community care team is fully apprised of what's going on, and when do you transition follow up back to that community-based team?
So a caveat with the endocrinologists is that we try, obviously, if the patient is already looking for another endocrinologist, we would continue to see them. But in all honesty, if there's a patient from the community that already has an endocrinologist and is needing just services of biopsy, ultrasound, a surgical consultation, if they can at all bypass the endocrinologist, I think that is the ideal. And I think that's what we should strive for. Because if they see the endocrinologist in the building at the thyroid center, the likelihood that they will go back to their community endocrinologist, unless it's a commuting issue, is very, very low. And that is because now they're in an entire building where they're not only seeing all of their thyroid doctors there, surgery or clinical, and their oncologists if they need to, if they're on a TKI, or their radiation oncologist. Now you have, the primary care team if they want to change a primary. I mean, I've had patients who are like, okay, I'm going to switch all my doctors to this building now, and and that's great for us. It's great for the health system. But I always fear that our referral base for our surgical colleagues would be hurt. But if the patient, is kind of in a place where they just needed to see us and go a long way for aggressive disease that we now consider stable, the thyroglobulin level hasn't moved, there's no recurrence in sight, I would say within 2 years of disease stabilization or lack thereof, they can go back to their community endocrinologist if they're seen by the endocrinologist on site immediately post-op. Great,
terrific. So another question from Dr. Brito from the Mayo Clinic is, we have struggled with protecting new patient slots, and we continue to have a large pool of return patients. So the more people you get in who go through this journey are now coming back for return visits. You mentioned you've implemented a new plan starting in January. Can you expand on that plan a little bit? How is that going to help to overcome that problem, other than bringing in more endocrinologists?
Yeah, so we do need to bring more endocrinologists, and we don't have, that doesn't seem like it's going to happen. We actually brought in a new endocrinologist not too long ago, but they're not necessarily thyroid focused because of the needs, obviously, of the diabetes, as you know, if you're an endocrinology faculty in a health system. We've changed the templates. So we've gotten feedback. So one of the things that I have strived for a long time, and for a brief period, we had a patient population, unfortunately, that was, for reasons we didn't understand clearly, we were having a lot of no-shows. So bringing up to the administration, like, we need to have protected new patients because we're getting referrals from surgery, we're getting referrals from the community, and patients are not being seen within the 72-hour window. If they're being seen by our surgical colleagues, they should be seen the same day. We need to block these slots. And the response that we got was, well, you have a show rate that's above 20%, and so you can't block those slots. So I would say the first thing you need to do, if that's an issue, which may not be, is attack the no-show rate so that you then have the leverage to go, okay, now we're booked to the max, our show rate is minimal, we need these patients to be accessed. And then you can also talk about the consequences of losing the business of bringing those patients in. But we actually changed our template. So we now have, our thyroid center coordinator has slots, particularly in my schedule, that only she has access to. And that's going to be, I think that's an hour, that's like two hours on Tuesday and 2 hours on Thursdays, because we get enough business from our surgical colleagues that we know those would be filled, so that our surgery patients are not waiting. Because sometimes our surgeons actually get just nodules that haven't been biopsied or worked up from the community, and we can expedite that process for them. So we have now blocked, and then I believe every hour has a 40-minute, every top of the hour now in every patient session for our endocrinology faculty has a new patient slots. Now, that's going to impact our follow-up slots, but what we're dealing with now is we'll deal with that problem when we get there, because our new patient access has been really impacted. And I think that the follow-up issue is probably something that needs to at least be expanded, if not by more doctors, by mid-level providers.
Great, thank you. Maria, could you just elaborate, in the ideal world, do you think that having everybody, it's one thing, we have the benefit of having a virtual experience, but in terms of having patients be able to go, it's not really virtual, it's live, but having everybody in one physical space, from endocrinology to surgery to cytopathology, do you think that is the ultimate model for a streamlined patient experience, or is that not as critical? There are pragmatic issues related to that, but is that the model that you think ultimately would give the best patient experience?
Yes, it would enhance the patient experience. I don't think it's going to enhance it to a critical level, with the exception that once you have co-location, you're in the same suite, now we have the entire administration is feeding that model. And I find, in all honesty, that I think it would bring more leverage to accomplish the goals that the faculty have for the patient experience, than when we are in separate suites. Because at that point, this geographic footprint sets a mark that everyone that serves it, not just the clinical personnel, but the administrative personnel, are all invested. Because as you know, the administration for our endocrinology division also takes care of the other programs for the endocrinology practice and the other divisions within internal medicine. So let's just say there's alignment of priorities within the different personnel in the thyroid stratosphere.
Great, terrific. So in the minute that remains here, could you just reflect a little bit on, if you had to do this over again, and with the benefit of the last several years of experience, and if you throw in a pandemic in between here, what would you do differently in terms from the outset that you think would make a difference?
I would advocate for recruitment of thyroid specific faculty for whatever reason. It was thought that myself, as the thyroid focused person, that they didn't need anyone else to be exclusively thyroid. And they did not take into account how many high volume thyroid surgeons we have. That is unique to our location. I've worked and trained in health systems where there are 1 to 2 high volume thyroid surgeons, maybe 3. And we have 6 here, and we have a couple at town. We have another, a few out west. So we need more. So I would say I would have advocated for that geographic footprint for us all to have co-located space from the outset with specific sessions where specific doctors would be there from the different specialties, and set a ratio of endocrinologists to surgeons, ideally thyroid focused endocrinologists to surgeons, ideally 4 to 1.
Great. Terrific. Thank you. Everyone, we're up against the 9 o'clock hour. I want to just again express my gratitude to Dr. Brito for an outstanding lecture. I do want to make a quick note that in light of Thanksgiving coming up next week, I wish everybody a wonderful holiday, and that we will not be live next Friday morning. So everybody enjoy the holiday season, and we will see you back on December 3rd. With yet another session here. So thank you everybody for joining us. Dr. Brito, thank you again. And everybody stay safe and stay healthy.
Thank you so much, Mark. You've been wonderful. Thank you, guys.